So, if you're a resident, picture this. You've got a patient in the ED right now with a nail bed injury. You might think it's just a surface issue, but exactly 50% of those injuries are actually hiding a broken bone.
Yeah, and if you miss that underlying fracture, I mean, your meticulous surgical repair is basically guaranteed to fail.
Right. Welcome to today's High Yield Revision Deep Dive. We are jumping straight in today, no fluff, just a rapid-fire question and explanation session entirely focused on fingertip and nail bed injuries, custom built for your FRCS plastic surgery board exams.
Absolutely. We're going to give you the actual clinical logic behind the facts so you don't just, memorize an algorithm. You need to understand the mechanics of the trauma.
Exactly. And hey, quick housekeeping before we scrub in. If you actually learned something valuable today, press follow and rate the show. Also, if you really want to lock down your revision, get a premium subscription.
Yeah, that's where you get access to the journal club and the clinical cases deep dives, which are just absolute gold for board prep.
Totally. So let's set the stage. The examiner hands you a fingertip trauma case. The very first thing we need to ground this in is the mechanism of injury. Why are examiners so obsessed with how this happened in different age groups?
Well, because the mechanism totally dictates the kinetic energy, right? And the zone of injury. So in children, these traumas are overwhelmingly caused by doors.
Oh, like fingers trapped in the hinge?
Exactly, the hinge or the jam. And that creates a very specific bursting type of crush injury. But in adults, it's almost entirely DIY tools.
Right. Hammers, drills, circular saws going rogue on a Sunday.
Yeah, exactly. And knowing that context tells you right away if you are walking into this blunt force explosion of soft tissue or, a sharp oblique amputation. It just sets up your entire surgical approach.
Okay, so you know the mechanism. You're looking at this crushed finger. The absolute immediate instinct is to just stare at the soft tissue defect, right?
Yeah.
You look at the nail, you start planning the reconstruction in your head.
Which is a classic trap.
Exactly. The very next step has to be ruling out deeper structural damage. So what is the absolute mandatory initial imaging requirement here, and what is the exact statistic the examiner wants you to quote?
Every single nail bed injury requires an X-ray. No exceptions. No clinical judgment calls.
None.
None. And the statistical reason you have to give them is that exactly 50% of these injuries have an underlying fracture of the distal phalanx.
50%. So treating a nail bed injury without an X-ray is literally like judging a book by its cover, but half the time the spine is literally broken.
That's a great way to put it, because the nail bed is intimately attached to the periosteum of that distal phalanx.
Right.
So if you spend all this time meticulously repairing the germinal matrix, but the bone underneath is mobile and unstable, the subsequent callus formation is just going to completely destroy the nail plate's ability to grow smoothly.
The whole repair just fails. Okay, so we've got our X-ray. We know the status of the bone. Let's look at the surface. Run through the 5 key classifications of nail bed injuries that examiners are ticking off on their score sheets.
Sure. You need to run through these systematically, from closed injuries all the way to complete tissue loss. So first, you have the subungual hematoma.
Okay.
Second, simple lacerations. Third are the stellate lacerations.
The bursting ones.
Right. Fourth is a severe crush. And fifth is an avulsion.
Okay, so we're moving from a closed pressure event through the linear cuts all the way to total tissue displacement. Now, once you classify it, the examiner is going to immediately pivot. They're going to ask for the surgical management plan for each specific one. Let's do a rapid-fire breakdown. Starting with a hematoma. What is the surgical difference between a hematoma with intact nail edges versus one with disrupted nail plates?
It relies entirely on the structural integrity of the nail itself. So if you have a hematoma but the edges are perfectly intact, the treatment is just trephination of the nail.
You're just venting the pressure.
Yeah, you're venting a closed hydraulic space.
Yeah.
You make a small hole, drain the blood, and that relieves the immense pressure on the periosteum without destabilizing anything else.
Right. It's like letting air out of a tire but leaving the tire on the rim. The biological splint stays put, but what if that nail plate is disrupted?
If the plate is disrupted, trephination is useless. You absolutely must remove the disrupted nail plate.
Because it's hiding the damage.
Exactly. It acts as a blindfold. The matrix underneath is so friable, and if the plate is broken, you just don't know the true extent of the laceration underneath. You can't repair what you can't see.
It makes total sense. Take off the blindfold. Okay, so push further into the actual soft tissue repairs. How do we manage the lacerations, the avulsions, and then those really nasty central defects?
Right, so for lacerations, simple or stellate, you carefully approximate them using fine dissolving sutures Or you can use skin glue.
The goal being a perfectly smooth track for the new nail?
Exactly. Microscopic realignment. Now, for avulsions, the protocol is to replace that avulsed tissue as a graft. You retrieve their own displaced tissue, prep it, and reconstruct the bed.
And central defects,
Yeah.
because those are just a nightmare. You've got a hole in the middle of a very tight, unforgiving space.
Yeah, they are tough. You can repair central defects directly, but, and you must explicitly say this in the exam, only after performing perinachial releasing incisions.
Okay, let's hover on that for a second. That's a massive mechanical concept. It's like pulling a tarp too tightly over a tent frame, right?
That's exactly it.
If you just drag the edges of a central hole together, you get massive tension. The second it swells post-op, those delicate matrix sutures are going to rip right through.
Which is why you make those perinachial releasing incisions on the lateral folds. You're basically borrowing tissue laxity so you can bring that central defect together with zero tension.
Zero tension is the goal. But what if the defect is massive? When do we hit the point where releasing incisions just aren't enough and we actually need a split thickness nail bed graft? What's the threshold?
The hard threshold you have to quote is 30%.
30% of the width.
Yes. If the defect is greater than 30% of the width of the nail bed, releasing incisions will fail. You need a split thickness nail bed graft.
And where are we taking that from?
The accepted donor sites are either an adjacent uninjured finger or a toe.
Okay, got it. Now, bringing this back to that 50% fracture rule from the start, we know half these patients have a broken distal phalanx. How do we manage that bone while we're doing all this microscopic soft tissue work?
Well, this is where the anatomy actually does you a favor. Because the nail bed is so firmly adhered to the periosteum, those fractures are normally reduced simply by accurately approximating the nail bed itself.
Oh, wow. So just by suturing the soft tissue, you're literally dragging the bone fragments back into alignment.
You are. It's a really elegant mechanism. And then once it's reduced, you just apply the nail plate on top.
As the splint.
Exactly, a rigid biological splint. But the caveat here is that if the fracture is highly unstable, that soft tissue tension won't hold it.
Right. And then what?
Then you have to escalate and use K-wires to mechanically secure it.
Okay, so approximate the bed to reduce the bone, splint with the nail plate, and pin it with K-wires if it's unstable. Perfect. So we've spent all this time on salvaging the tip, but eventually you get a trauma that crosses the line. The tissue isn't just crushed, it's gone.
Yeah, amputation.
The math changes completely here. And the optimal management of fingertip amputations is highly controversial in the literature. Right?
Oh, heavily debated.
But even in a debated topic, examiners want rules. There is one non-negotiable principle regarding the thumb. What is it?
You have to state clearly that reasonable attempts must always be made to preserve the length of the thumb. Always.
Because it's so vital for function.
Right. The thumb dictates up to 50% of your overall hand function. You need a rigid, long post for opposition and grip strength. If you sacrifice thumb length, you devastate the entire hand's mechanics.
Always fight for thumb length. Okay, moving to classifications. We know Tamai and Ishikawa are out there, but Allen's classification is the classic exam staple. Break down Allen's types I through 4 for us.
So Allen's classification is based entirely on how far proximal the amputation goes. Type I is pulp only.
Just the tip.
Right. Type 2 is pulp and nail bed. Type 3 involves a distal phalanx fracture with the associated pulp and nail loss.
Okay.
And then type 4 is everything loss of the lunula, the distal phalanx, the pulp, and the nail.
I just visualize that as walking backward down the finger. You start at the pulp for type 1, step back to the nail apparatus for type 2, chew into the bone for type 3, and then step all the way back to wipe out the lunula for type 4.
That visual of stepping backward is honestly the most reliable way to remember it under exam pressure.
Okay, so once you classify it, you face this insane matrix of reconstructive options. Let's start with the best case scenario. When can we just replace the amputated part as a composite graft? What are the strict criteria for that to actually work?
For maximum success with a composite graft, meaning you're just reattaching it without microsurgical plumbing, it is most successful in children under 3 years old, provided it's replaced within 5 hours.
Under 3 years old, under 5 hours. Why that specific window? Is it just the metabolic demand?
Yeah, and the immense vascular plasticity of toddlers. They can survive on purely plasmatic ambition just long enough for new vessels to grow. But after 5 hours, or in adults, the ischemic time just causes irreversible cell death.
Right. So what happens when you can't do that? Say it's an adult or it's been 12 hours. If bone isn't exposed, what does the data show is actually the best option? And let's compare this directly against skin grafting.
This catches so many residents out. If bone is not exposed, healing by secondary intention is considered by many to be the absolute best option.
Oh, wait, really? Better than a skin graft?
Yes. Studies consistently show you get superior functional results just letting it heal on its own compared to a skin graft.
How does that work functionally?
It's all about coverage quality. A skin graft on the fingertip lacks durability and sensation, but secondary intention relies on wound contraction, which physically pulls the native, highly sensate pulp skin concentrically over the defect.
So you get better sensation and mechanical durability?
Significantly better.
Okay, but what if the bone is exposed? Because you can't just leave a shard of distal phalanx out in the open and tell the patient to wait for it to heal.
No, you can't. But the clinical bias towards secondary healing is actually so strong that the standard protocol is to just shorten the exposed bone.
You shorten the bone just to avoid a skin graft.
Yeah. You bite it back just below the soft tissue level so that superior healing by secondary intention can happen over the shortened tip.
That is wild. We're literally willing to sacrifice bone length for native sensate coverage, but that leads to the elephant in the room. Exams love the alphabet soup of local and regional flaps. If secondary intention is so great, what is the crucial prerequisite for choosing a complex flap instead?
The surgeon must be completely satisfied that the outcome will be definitively superior to bone shortening and secondary healing.
Gotta push back though. If that's the rule, why are we taught 8 different flaps? Are we just doing surgery for the sake of surgery?
I mean, it seems that way sometimes, but the data shows that rates of cold intolerance and altered sensation are remarkably similar between flaps and secondary intention.
Oh, so the flap doesn't save them from cold pain.
No, it doesn't. You only use a flap when shortening the bone would compromise critical function, like, preserving thumb opposition, or if they need the length for their specific job.
Okay, so it's a structural necessity, not a magic bullet for sensation. Let's list these flaps because examiners love them. Start with the VY advancements.
So these borrow laxity from the adjacent pulp. You have the Addusoy-Kleinert volar VY flap.
That's the volar one.
Right. Then the Cutler lateral VY and the Segmuller lateral VY.
Okay, so cut a V, push the sensate tissue forward, and close it as a Y to avoid tension. What about the advancement and island flaps?
For those, you have the homodigital island flap, the Venkataswamy advancement flap, and the Evans step advancement flap.
And lastly, the regional options, when local tissue is just totally devastated.
Then you're looking at your crossfinger flap and the thenar flap.
Okay, Addusoy-Kleinert, Cutler, Segmuller, homodigital, Venkataswamy, Evans, crossfinger, thenar. You just have to memorize the list.
Now let's close out with surgical landmines. 2 major post-op complications for the nail bed that you must avoid. What's the first one?
The first is a hook nail. This happens if you leave tension on the nail bed during your inset.
Oh, back to the tarpon tent analogy.
Exactly. As the scar contracture sets in, that tension acts like a lever and literally pulls the nail matrix volar ward over the bone. The nail grows out in a downward hook. So avoid tension. Avoid tension. Avoid the hook nail. What's the second complication?
It happens when the trauma leaves you with very little original nail bed. The strict rule is, if less than 25% of the nail bed remains, you must completely resect it.
Completely remove it. Why? What happens if you try to be a hero and save a tiny remnant?
Well, the germinal matrix's only job is to produce keratin. If you leave less than 25%, there's no sterile matrix to guide its growth.
Oh, so it just grows randomly.
Yeah, that disorganized tissue will just endlessly churn out painful shards of keratin under the skin. You get chronic nail spikes and cysts.
So trying to save it condemns them to a lifetime of painful shards. Less than 25%, resect it completely. Slam dunk rule.
Knowing when to cut your losses is just as important as the reconstruction.
Absolutely. Well, that wraps up this rapid-fire deep dive. We hit the mechanisms, the mandatory x-rays, Allen's classification, and all the reconstructive algorithms. Hey, reminder, hit that follow button, leave us a rating if this helped your revision, and grab that premium subscription so you don't miss the Journal Club and Clinical Cases deep dives.
And as you go back to studying, I want to leave you with a conceptual question. We talked about how cold intolerance and sensory outcomes are basically the same between complex flaps and simple secondary intention.
Right.
So outside of preserving absolute bone length, why do we maintain this massive arsenal of regional flaps? When is a Venkataswamy or a cross-finger flap truly the only viable choice?
That is the exact kind of higher order thinking examiners want. Don't just regurgitate the flaps, understand why they exist. Drop a comment or a question below with your thoughts on that. Good luck with your revision, keep grinding, and we'll catch you on the next deep dive.